Hello. Like he said, I'm Allie Wilkerson. I'm a licensed clinical psychologist. Spend most of my time doing research these days in the dissemination or getting out of evidence-based treatment, assessment and treatment for sleep and mental health disorders, particularly in specialty populations. So I'm also lucky enough to be the clinical director at MUSC, an associate professor there, the clinical director of our Sleep, Mood, and Anxiety Research and Treatment, or SMART program. So we are kind of a specialty group that sees folks with one or all of those problems, and I'll talk a little bit more about that in a minute. So today, oh gosh, let's see if I can figure out what. Nope. Is this what I hit? There we go. Okay, so today we're going to talk about, so we've been in physical health all morning, right? Now we're going to do a kind of a flyby of emotional and mental health in this area, in this field, in this population. And so, first of all, what do we know about EDS and mental health? So this is a systematic review that was done looking at all articles from 2011 with the terms Ehlers-Danlos Syndrome, psychological, and mental disorder, which I'm not a huge fan of, but I didn't do this review. And they found a total of 23 articles that looked at prevalence of mental health or mental disorder in these groups. And so they found 23 studies with a total of around 12,000 participants combined, a little over 4,000 with EDS, so there's a bit large comparator group there. And this is how they broke down. So cross-sectionally, there were 10 studies that looked at cross-sectional studies, 3 case studies, 3 chart review, and 7 others. So that's like validation studies, qualitative analyses, those sorts of things. And interestingly, so this first graph shows what they looked at, right? So the number of studies that looked at each of these things. So mostly people were looking at mood disorders, so like depression, bipolar, secondary anxiety, and third neurodevelopmental. And interestingly, what they found in terms of prevalence was the opposite. So highest level of, or highest percentage of neurodevelopmental, followed by anxiety, and then depression. Bipolar is a part of this picture sometimes, but it's a pretty small piece, so that didn't make it. Now, mind you, even though depression is the lowest prevalence here, that is still no joke of a number. That's still a really high level or a high percentage of folks with depression. So this is sort of the picture of what we're looking at here. And just don't try to read this. I just want to note here that of these 23 studies, so they looked back to 2011, right? And pretty much all of them start 2015 or later. So this area is growing big time. We are woefully behind, I think, and have a lot of work to do, which I think is the theme of today, it seems like. But things are growing. The other thing to note is that where these studies took place, only 2 of them collected data in the United States. So like, we need to get moving. We need to catch up. So what about sleep? So sleep is also a really big picture of what I do, and sounds like a very big part of the picture in this population. And so what I pulled, I could find a lot saying that there were sleep problems, but not any really large studies about sort of describing those problems or what to do with them, right? So here's one example, which was a larger study. So a 2022 survey of 768 adults, 92% said that sleep was not restful, right? Like that's everyone. 66, so the majority of people are not sleeping the recommended, 7 to 9 hours at night, with just about everyone reporting that pain is interfering with sleep. Probably not surprising to anyone in this room. Then I looked at interventions, which I could not find a lot of, again, in this literature. And maintaining routine was the biggest, like trying to be consistent, followed by prescriptions and OTC medications. What's not on here is behavioral interventions, which makes my heart so sad because we have really good behavioral interventions for sleep and things like insomnia that help sleep and thus help pain, right? That reciprocal relationship between sleep and pain. We may not be able to directly make your pain better, but we can help you sleep better. There's all kinds of nuance for pain in these interventions, and that then when you're sleeping better, you feel better, right? So that is the picture here in our very own homegrown by our very own MUSC clinical registry with our very own Victoria Daler pulled these data for me, and I'll just orient you a little bit. These are not published, so please don't share.
But over here on the left, we've got, I'm a pacer, so I'm like trying real hard to stand still here. So over on the left, we've got which of the disorders we're talking about, right, when it comes to mental health and sleep. And then we've got prevalence. So we've got our HEDS versus our HSD. And you'll see that the prevalence rates are pretty high. Look at anxiety, right? It's up there. And this is not surprising for a couple of reasons. One, the time it takes to really get to diagnosis and figure out what's going on in this really complicated clinical picture, and people telling you it's all in your head or you're crazy and those sorts of things, can breed fear and worry that can then become patterns, right? So that's sort of one side of it. The other is that anxiety in a lot of respects is hypersensitivity, right? So they are the same thing in a lot of respects. And so our goal is to make sure it's the right amount of that hypersensitivity when we're working with this, with anxiety in anyone. And so followed by depression with several others. As you can see there, I won't read it to you. But what was done here, so in the fourth column, looking to see if there was any difference in these two different presentations, right? HEDS and HSD, and you can see that there really isn't. These are pretty problematic in both groups. And then compared to all of us, compared to the general population, we see rates are much higher. And so when I look at insomnia, we typically see 10 to 20% prevalence of insomnia, and here we've got 30 to 40%, which is a really big deal. And then we look at, again, from that registry, we see co-occurring diagnoses, right? So a page list of other diagnoses and disorders and syndromes and conditions. And if we look at the average number of co-occurring diagnoses, we've got HSD has an average of 17, and HEDS has an average of 25 co-occurring conditions to be considered in this whole kind of picture, right? So how do we approach this? So this is a paper that came out by a group that is starting to kind of conceptualize this, and they talk about assessment of this neuroconnective phenotype. And I'll break these down a little bit. So they use the form somatic a lot, which I think now feels like a little bit of a negative connotation. I wish we could call it idiopathic mind-body sensations or weird things happening in the body that we don't have a name for yet, but that's why they don't let me name things. So in this, it's all related to sort of the somatic language. And so when we think about somatic symptoms, we think about things like chest pain that's not related to cardiac disease, dizziness that seems, unexplained. When we think about somatic illness, that's when a cluster of those get together and have a diagnosis, like fibromyalgia or chronic fatigue, those sorts of things. And then somatosensory is related to senses, right? So olfactory sensitivity. Thinking about those things. Then at the bottom, we get to more of my wheelhouse. So behavioral is thinking about how do we deal with things. And a lot of times in extremes, so fight or flight, avoidant or dependency, assessing those kinds of things. And then psychopathology is those more diagnostic criteria: anxiety, depression, bipolar, PTSD, psychosis, and really considering all of these different areas in our clinical picture. And very coolly, they have a proposal for how to evaluate, how to assess each of these domains, right? So the blue is self-assessment that someone can do on their own. The green is clinician-administered, and admittedly, some of these require some training. So the mini that they suggest in the psychological group is something that you need a good bit of training for, but just really cool that they've kind of put all this together and made it tangible and said hey, do this, which is, again, feels like something we should have done decades ago, but is only being put together kind of recently. Okay, so what about treatment? And again, another kind of recent review looking at, pulling any papers that have reported on treatment of some kind of mental health symptom or diagnosis in someone with EDS. They came up with 10, guys, 10 case control and cohort studies. And I won't get into all these different kinds of therapy, but we've got 4 that are CBT, that's sort of where I live. It's cognitive behavioral therapy, how our thoughts, feelings, and actions interact with each other, and if we just poke at one of those, we can change the others. 1 dialectical behavioral therapy, which was
creative for folks with personality disorders. It really focuses on emotion regulation, distress tolerance, interpersonal connection. And then 2, psychoeducation, just like here are symptoms, here's what's going on. 1, I don't know what intensive interdisciplinary pain treatment is, but it sounds awesome. I'm all for anything interdisciplinary. And then 1, ACT. So this is what we often do for our folks with chronic pain or chronic illness, and it's called acceptance and commitment therapy. It's being accepting of thoughts and feelings, and really sort of being an observer of your thoughts and feelings. There's a lot of focus on mindfulness, those sorts of things. So quick flyby of those. Generally, we still don't know a lot. They helped, but didn't help necessarily immensely. The interventions weren't described really well, small sample sizes, and I could not, I looked, there might be one out there that I didn't find after an hour of searching, but I could not find any randomized clinical trials really digging into this, which is what we need in science, right? And so there's a lot of work we can do here. But it does seem like from these kind of preliminary studies that there is hope that some of these evidence-based things we do can be tailored to this population to really help. So take-home points there is a high prevalence of emotional and mental health and sleep stuff going on in folks with EDS. Useful conceptualization models are being created and refined. Hopefully we'll continue to refine them, get some kind of updated language in there. And then, the mental health treatment literature is behind, and I said woefully lacking because that's how I felt about it. But we are, I think I choose to see this in a hopeful light in that we can move in this direction with the momentum that's going in the literature and with things like this, and we can make a change there. And so I wanted to tell you a little bit about our clinic. So if you come to our clinic or you send anyone to our clinic, we do a 60 to 90 minute intake where we get a full mental health and sleep history. We do that mini that I was talking about earlier. And then we make a plan. We have a wonderful team of psychiatrists, psychologists, and LPCs, or licensed professional counselors. And then you will see someone weekly, bi-weekly, and they are all trained and have had lectures and learned about, and we have several patients that have EDS, and so feel free to send anyone our way. Please use my email address or our clinic email address if you do that. I love MUSC. I came here for training and never left, so I'm on year 11 of the one-year plan. But our scheduling and phone tag team is not great in a lot of ways, which I'm sure you've experienced. So please use those emails if you would like to come our way or send someone our way. We should be able to get back to you pretty quickly. So I'm happy to take questions. On the one hand, I want to be mindful and respectful of the idea that we're behind. And on the other hand, I want to be mindful and respectful of the fact that it seems like today's space is being made in a place where space is often not made. And so I saw there were several questions in the app that I will get to. Happy to take one or two here if we have time, whatever you guys think. Yeah, I saw this hand go up first.
What about recently looking at the ketamine therapy for anxiety and depression? What is your opinion of that as far as in relation to, in general and
Sure.
in relation to EDS?
Sure. So the question was, what about ketamine therapy? This is popping up like crazy everywhere. Back in my day, ketamine was called Special K, and it was only known as the date rape drug, right? So when this came on the scene, it was kind of terrifying. Now, we do have several clinical trials showing it can be really, really helpful, especially for things like treatment-resistant or treatment-refractory depression. However, there are lots of clinics popping up out there that are not reputable and that you should definitely be wary of. Anyway. And so I would just do your research on the specific clinics, but know that it can be a really helpful, useful treatment for folks.
Okay, so I've had multiple psychiatric evaluations, and I don't know if that's been the case for a lot of people, but as a child especially. I feel like in general, I was diagnosed with a lot of things I didn't have because with EDS and the comorbidities that come with it, the physical issues with mast cell and POTS, they can manifest in psychiatric disorders that might not be able to be treated as in the CBT, DBT ways, and instead need more of the medical interventions. How is your psych eval different where you might look into maybe more of the medical treatment, or are you thinking about that?
Yeah, that's
because
a great
it is
question.
important that psych evals are done for people with like medical trauma or PTSD or ADHD and all that, but just like being wary of also the physical issues that cause that.
Very common thing and very frustrating, so I'm very sorry. So my answer is like we don't tease it apart. What we say is, like, especially for things like chronic dizziness, for example, it's like we can't tease out what's that and what's this. What we can do, so for anxiety, what we can do is we can give you all the skills that we have for anxiety, so that whatever pieces of this are anxiety, then those can go down, and we can figure out what's left physically to deal with. And I think just being educated on the rare disorder or the chronic condition that you're dealing with, any provider that can help. A lot of times if you're in a clinic where it's just like we need to give a diagnosis and send you on your way, a lot of that kind of stuff is missed.